How's your demonstration of facial jerk? Because they just went like this to me, my face.
No.
Thank you.
Gotta go now.
Thank you so much for joining us. We have a series of free community events available.
Okay, so I'll hold these till the end then.
Yeah, you could even say including this Monday.
14th and the 29th.
You're doing that talk too, aren't you?
Is there going to be, this is on our website, or where can they find this?
It was going to be then, but he looked like crap.
Okay.
He looked like he was hurting. I was just rounding up there with them. I said, "Are you coming with me?"
Okay.
And he says, "No, Karan's going." And that's why I called you.
We are live on YouTube right now, so.
So I should be able to pull you up?
Well, on YouTube, not on Facebook yet.
Oh.
YouTube is live as well.
So we can cut, right?
Everything is
She said yes.
You-
Cut and redo?
Oh, absolutely.
No.
All right, you guys
Actually, I
live?
was just explaining
So
to
that's
him
not
that
live.
it's all live. It
This is
is
live.
live.
It's getting ready to go live right now.
On YouTube?
And Facebook.
I didn't know YouTube was live.
Tell me
That
when
was
you
on
when I
recording.
can start.
Well, they record
Right
it
now?
after. It keeps it recorded.
We're on now?
Okay, we're on now. All right.
Smile.
Good afternoon, everyone. Thank you for joining us for this Facebook Live. This is May Stroke Awareness Month, and we are here today to talk to you a little bit about stroke and stroke symptoms, and also to give you the opportunity for you to ask questions. My name is Michele Shain. I am the Senior Director of Neuroscience and Cardiovascular Services at Bakersfield Memorial Hospital. And with me on our panel today is Alida Lorenz. She is our nurse manager for neuroscience at Memorial. And our doctor, Dr. Kiron Thomas, he is our neurointerventional physician at Memorial. So, let's see. Questions coming up. Any questions for our panel today?
Hello, Cyberland.
So while people kind of get geared up, let's talk about just some facts about stroke. Do you guys like to share just some basic facts about stroke that the public might want to know about?
That's me. Thank you.
You're on.
Hi, I'm Dr. Kiron Thomas. I'm a neurointerventionalist, director of the stroke program and neurointerventional program at Bakersfield Memorial Hospital, Dignity Health. I believe I'm standing in for my partner, Dr. Dan Moody. He's a neurointerventionalist, but unfortunately decided to break his finger last night. Anyways, stroke, coming back to the main topic. Stroke refers to irreversible brain injury from an acute vascular event. It could be either a hemorrhagic lesion, a hemorrhagic problem, where there's a bleeding or leakage of a blood vessel, or it could be a blockage or an ischemic stroke. It is one of the most burdensome diseases that mankind has ever been afflicted with. Fortunately, with recent advances in medicine and stroke care, it is not now the most leading cause of death in the United States. It is, I believe, 4th or 5th at this point, but it's still the most burdensome, the most morbid of all diseases that we can think of. The reason is even a small or minor stroke, what we think is a small stroke, could still be devastating and leave people out of their meaningful and productive life. The reason for that is the brain, the limited plasticity and regeneration capacity of the brain, which leaves us with less brain to work with, for lack of a better term.
Yep. So this is the #1 disabling disease.
Okay, thank you. So when we're out and about in the community, we use the acronym ACT FAST. Alida, do you want to talk about that?
Sure. So FAST is something that's easy to remember, and what it stands for is the F is for face. So does one side of your face droop down, okay, or does somebody's face droop down? A stands for arm. Does one arm drift? Can that person raise both arms up? S is speech. Is there a sudden change in their speech? Okay, what is important about this is it is sudden. Are they speaking funny? T is time to call 911, and we can't emphasize that enough. We work very closely with county emergency medical services to actually engage our stroke system of care upon that call. So we are actually mobilizing our team within the hospital the minute that we hear that there's a potential stroke, which gives us time because you actually lose 2 million brain cells every minute that you have a stroke. So time is brain.
Absolutely.
Mm-hmm.
Okay, so we have some questions coming in. We have one from Kat Dowdy. Kat's question is, if you have medium-high cholesterol, should your doctor immediately put you on statins to prevent a stroke?
That is, a discussion between the patient and the primary care physician, depending on the patient characteristics, demographics, and also what has been done previously to limit the adverse effects of having bad cholesterol. So, bad cholesterol does not cause a stroke immediately. This is whatever causes a stroke is in the works for years or maybe even decades. So important thing is to have good control of your cholesterol and good control of your blood pressure, but this is not a 1 day or a 1 week thing. It happens over months and years. And whether you need medication for lowering your cholesterol, again, is a discussion between you and your primary care physician, depending on how long have you had that for, how bad it is, and also what other measures you've taken to try to limit the problem. So control or treatment of bad cholesterol could include lifestyle modification, or may start with that, and at some point it may not work enough or work well enough, and you may have to go to medications. So that is a discussion between you and your primary care physician.
Okay, thank you. And we have Amelia Barnett speaking up and saying hello. Hi, Amelia. If you have any questions, please send them to us now. But we've got some other questions. So you talked about, briefly, you talked about what stroke is earlier in the opening. Is there one type of stroke that's more dangerous than another?
Not necessarily, because the two major types of stroke is ischemic and hemorrhagic. So one hemorrhagic stroke can be fatal immediately, depending on the size of the hemorrhage and the location of the hemorrhage. It could be fatal immediately. But when we refer to stroke, conventionally we refer to ischemic stroke, or a blocked blood vessel, rather than a leaky blood vessel. So the hemorrhagic stroke, or which is conventionally referred to as brain hemorrhage, for most part is different from the entity of ischemic stroke, which usually is not life-threatening. It's not fatal unless it's a huge stroke. It does not take one's life. On the other hand, can leave you devastated with significant morbidity and mortality and disability. But hemorrhagic stroke, if you want to, an answer for that to that particular question, yes, hemorrhagic stroke can be fatal in the immediate vicinity of the event.
Okay. Okay, thank you. So this question is from Chrissy Lager. My daughter had a brain tumor removed 3 years ago and diagnosed with grade 4 glioblastoma. She's now in remission but has constant headache and pain, but the doctor hasn't done much for her. Suggestions?
Unfortunately, is outside the scope of today's discussion. She certainly deserves better pain control as much as possible, and better workup to understand if there's anything else other than the headache or the symptoms that you can expect post-surgical or with residual tumor, if there's any. Unfortunately, I cannot give you specific instructions or advice on that. We'd be more than happy to have you seen by myself or one of my colleagues, but that is outside the scope of today's discussion.
Okay.
I'm sorry.
Okay, great. Okay, and next question we have, are there screenings that I can get to help determine if I'm at risk? Alida, you want to take that one?
Yeah, so Dignity Health Memorial actually has recently opened our Neuroscience Institute, and which is actually having an opportunity with our Dare to Care program for the free vascular screening. Information for that we can post actually on here if you guys want to follow up on that. So what that vascular screening entails is actually an ultrasound of your blood vessels, your carotid arteries specifically, to look for blockage. That's one risk factor. And then it's also going to look at some other vessels as well. And you're able to assess your risk factors that way.
Okay, so thank you. Okay, so treatment for stroke. Can you share, either one of you, Dr. Thomas or Alida, what the treatment options are for stroke? So since ischemic stroke is the most common kind of stroke, about 80 to 85% of the strokes that we see are of the ischemic nature. So maybe we could start with treatment options for that.
Treatment for ischemic stroke is primarily or broadly categorized into two phases. One is the acute phase, the in-hospital phase, and even within the in-hospital phase, there could be several periods of time, the hyperacute phase and then the acute phase, and then the long-term rehabilitation. So we are not going to talk about long-term rehabilitation because that's in the realm of physical therapy and occupational therapy, getting the patient who suffered a stroke back into productive life as much as we can. The acute phase of care, which consists of both the hyperacute and the acute phase, the most important thing is recognition, rapid recognition of symptoms. That is a huge part, even though we may think that's a diagnosis, but that's a huge part of treatment because that will determine what type of treatment that the patient may be eligible for. So conventionally speaking, in the appropriate time frame, if the patient presents within the appropriate time window, you can consider intravenous thrombolytic therapy, a medication that's supposed to dissolve the clot that's blocking a blood vessel. And then, if that doesn't work, again, for the appropriate patient candidate, you can consider endovascular therapy to try to recanalize the blocked vessel. So that's broadly what we do in the hyperacute phase of treatment. Then the acute phase of treatment, how to prevent another stroke from happening, is medications that prevent the blood from clotting too fast or being too sticky than usual, which includes medications like aspirin and medications similar to that. But that is all actually secondary prevention rather than treatment of stroke. Treatment of stroke is trying to limit the damage that the blockage has caused and then to rehabilitate the patient from the damage that's already suffered. Everything else is actually secondary prevention, trying to prevent the second event from happening.
So as a nurse, my job is to translate for the physician, correct? Into layman's terms. So just to clarify, that treatment with intravenous medication is actually treatment that is initiated through your vessels, right? And that can be given up to 4.5 hours. But every minute, your chances of recovery are getting worse, right?
So,
and then
4.5 hours, excuse me, Alida. So 4.5 hours is the time frame from when the patient symptoms began. So when we're triaging a patient and assessing a patient, we always ask the patient and or their family or whoever is accompanying them, when was this patient last to be known in their normal state? So that is the time that we start the clock, and it would be 4.5 hours past that we have the opportunity to treat with IV thrombolytics. Beyond that 4.5 hours, we now have the benefit with Dr. Thomas and Dr. Dandamoody on service at Memorial Hospital. We have options that we can offer patients in our community for treatment beyond that 4.5 hour mark. So do you want to talk specifically? You mentioned endovascular, but share with them really what that is and really what a tremendous benefit it is that we have in our community.
So going back to the first part of the treatment, the intravenous thrombolytic, which Alida kindly explained to you in layman's terms. So that is the approved standard of care. The FDA-approved treatment for acute ischemic stroke is intravenous thrombolysis with a medication called alteplase. Sometimes, if it's a large vessel of the brain that's occluded, alteplase has limited chance of opening that vessel up or dissolving that clot up just because of the burden of the clot itself. In that circumstance, for those patients, or if for any reason the patient does not qualify for the intravenous thrombolytic therapy, we have a very strict window or criteria that makes a patient eligible or ineligible for IV thrombolytic therapy, which may include the time of onset and whether the patient is already on a blood thinner, how thin their blood already is, things like that. So if for any reason the patient does not qualify for the IV thrombolytic therapy, then that doesn't mean that we stop our treatment there, we stop our efforts there. You always think about other ways of opening up a vessel, especially a large vessel that's occluded, by other means. And that is, at this point, done by endovascular route, meaning you go through the artery, directly into the artery that is blocked, and try to fish that clot out with either just suction or special devices called a stent retriever. So that is endovascular reperfusion therapy. And in the last few years, about 3.5 years or so, there's been overwhelming and mostly irrefutable data that supports the use of endovascular intervention in select group of patients. The data demonstrates that there is excellent clinical benefit to be derived for those patients.
So I often liken an ischemic stroke in the brain like a heart attack in the heart. It's the same mechanism where the vessel is occluded from plaque or from blood clot, and blood can no longer flow beyond that. So the endovascular treatment that Dr. Thomas is talking about in providing or restoring blood flow to the brain can be compared to patients receiving angioplasty or a stent placed in the heart. It's the same similar kind of thing. It's done in the same kind of laboratory. They go in through the femoral groin with catheters, and in this case, they thread those catheters all the way up to the brain and either dissolve the clot, pull the clot out, put a stent in to restore that blood flow. Okay, so thank you. So I do have some other questions. How serious, I like this question, how serious is a TIA? So I lovingly like to call the TIA take immediate action, because it's like an invitation to a worsening event. Well, you want to take that?
Absolutely, yeah.
You want to take it?
I wish I could claim credit for that, but TIA, I think it's more important than the stroke itself. First, because stroke, by definition, means irreversible brain injury, and that there's no way to salvage the infarct, the brain territory or the brain tissue that's already been damaged. There's no way to restore that. TIA, on the other hand, is a warning. And that means the body or the brain in particular is giving you a chance to act on. So if you make use of that warning, if you pay attention to it and do the appropriate thing, chances are it may prevent the stroke from happening and significantly alter your life otherwise.
Okay. In fact, we actually work up a TIA patient the exact same as we would an ischemic stroke patient, as far as the care that we provide in the hospital. You know, we do currently admit you. We do currently want to find out what those risk factors are and hopefully prevent that reoccurrence, right?
That's right.
So can you share with our audience what are some of the risk factors for stroke, and how would one reduce that risk?
I had a wonderful medical director one time that taught me an easy way to remember this, and we called it the stroke ABCs. So because there's just about every letter of the alphabet that has a stroke risk factor. But the big ones that you can't change are important to know, but you can't change them. Okay, the important ones, age. As we age, we have an increased risk factor. You know, genetics, people have that, okay? But the really, really big one is that B, blood pressure, okay? We can control that. We can control the blood pressure. C, cholesterol. Somebody asked a question about cholesterol, right? It's easy for me to remember if I do it this way. D, diabetes. Control your diabetes. We have control of that, right? What is it now? 80% of strokes are preventable. So, so D, diabetes. E, exercise. Okay. I forgot up and C, cigarettes. You smoke, don't smoke. Okay. We all know that, right? but it does increase your risk factors. F, obesity. Okay, I didn't use the F word, but
So we got you.
yeah. So there's a lot. There's some that you can't change. There's some that you can change. Hormones can be a risk factors. It is known and it's been demonstrated that women have more strokes than men, and there are a number of reasons for that. Do you know what those are?
More brain.
Or brain. I attribute it to the fact that we live longer, or we put up with you.
So, there are modifiable and non-modifiable risk factors. So, the non-modifiable risk factors, there's not much point in discussing that ad nauseum. But the modifiable risk among the modifiable risk factors, smoking and hypertension. So there's a study that came out probably 2 decades ago that if you reduce your blood pressure, your systolic blood pressure by about 10 millimeters of mercury for people who are hypertensive, who had uncontrolled hypertension prior to the endeavor, if you reduce the systolic blood pressure by 10 millimeters of mercury, you're reducing a risk of stroke by almost 50%. So that's how important control of hypertension is in prevention of ischemic stroke. And then cigarette smoking. So these two things, if you can control that, if you can modify those risk factors, that'll go a very long way in preventing a stroke. But again, sometimes stroke is just not preventable, despite your best efforts. Even the modifiable risk factors, it's difficult to modify them. The unmodifiable risk factors, of course, is beyond your control.
Okay. All right, so if I start to have some stroke symptoms, what should I look for and what should I know when it comes to calling the ambulance, and what would I tell them to impress the significance of the symptoms?
Well, if you can identify that you believe you're having a stroke, just saying that you're having a stroke is going to initiate that rapid response. But as far as what to tell them and what to have with you, you already mentioned the last known normal time or last known well time. That is probably the most important, is when do you believe that this happened? When were you normal and when did this start? And then also any significant history. We are going to need to know when you hit the emergency room what medications you've had. Have you had any recent surgeries? Because as Dr. Thomas stated, there is only a select amount of people that will qualify for this initial treatment. Once you hit the emergency room, we will perform a scan of your brain that will give us some images and immediately determine whether you're having a hemorrhagic stroke or an ischemic stroke. That is what we are attempting to do. And then we will begin this history workup. Anything else that you would want as a physician?
Yeah, rapid recognition of stroke or stroke symptoms is key. The brain, unfortunately, is not like one homogeneous organ structure. If it was in different parts of the body, we probably would have called it different names, because the different parts of the brain perform different functions and control different parts of the body. For that reason, the symptoms you can expect with a stroke varies according to what part of the brain is involved. So what symptoms constitute stroke? In fact, everything that you can think about that makes a person a human being. So higher cognitive functions, the ability to think, understand, produce language, understand language, vision, the ability to see and perceive vision, mobility, move and execute actions, sense things. All these are neurological functions ultimately controlled by the brain. So depending on what part of the brain is involved, you can have different sorts of functions. However, if you look at the anatomy of the brain, there's a substantial chunk of the brain that is entrusted with two parts of the body. One is the face and the other is the hand. Not the arm, just the hand. So if you want to look for the highest yield symptom in an acute ischemic stroke, it is the face and the arm. And that constitutes part of the FAST campaign, the face, arm, and speech. And why is speech there? Because anything that involves the face, the tongue, the throat, can all obviously produce trouble with speech. So that is the FAST campaign right there, face, arm, speech, and then you look for time. And recognition of symptoms is almost like 50 to 60% of the acute treatment of stroke. So that's how important it is.
Okay. So where did it go? I just want to share with you, Dr. Thomas, Alex Bernal wrote in with a comment, "Thank you, Dr. Thomas, for saving my wife."
Oh.
So that's great. Thank you for sharing that with him, Alex.
That's kind of you, Alex. Thank you.
So we talked about recognition, evaluation, diagnosis, and treatment of stroke. Tell us a little bit about the care and the management of stroke patients. So I would like the community to know that on March 2nd, we formally opened our neurocritical care unit, 8-bed critical care unit designed specifically to care for those most ill patients in our community from neurological conditions. So we have treatment options available. Now we need to manage them and take care of them. Can you guys talk about that?
Sure. Alida, you want to go first?
Yeah. Well, you're one of the physicians that's in that neurocritical care unit, so you might
believe
want
it
to.
was February 28th, not March 2nd.
Well, March 2nd was the first patient
Oh, is that right? Okay.
that we saw.
I was still working.
And
You weren't paying attention to dates, were you?
yeah. So as far as management of the patients within that neurocritical care unit.
Why is that different than just putting them anywhere in an ICU bed?
Specialized care. So we have clinical experts in neurocritical care that are involved in every single case that is within that unit. So that specialty care includes physicians that are on every case, and as well as trained nurses. So our nurses have been trained in emergency neuro life support and also specialized set of classes. So it's going to affect outcomes, we hope.
Yeah, stroke care has come a very long way, since its first description thousands of years ago. And, until maybe a couple of decades ago, stroke care was essentially, living with the deficits. And sometimes it's fatal, which, as I said before, is rare in the case of ischemic stroke unless it's a huge stroke. But otherwise, people are just left alive to suffer the deficit, the disability. But we have come, especially in the last 2 decades, we have come a long way. And with every passing year, we have made significant advances in understanding the pathophysiology of stroke and the immediate aftermath of stroke when it happens. And just like recognition of stroke is complex as opposed to some other conditions or symptoms. For example, if you have a heart attack, the diagnosis and the recognition is pretty much linear. Like, you have chest pain or shortness of breath, do an EKG or enzymes, and you pretty much have a diagnosis there, and then the treatment decision is also fairly straightforward. In stroke, as I said, the symptomatology can be, it could be a myriad of symptoms. It's difficult to make sure whether this is a stroke or something else because there are a lot of stroke mimics like migraine or seizures, sometimes just, factitious disorders or even psychiatric issues. So we have to weed out all these confounding symptoms or presentations and finally determine who is the patient who is having a real stroke and to treat them appropriately, because some of these treatments can be fairly invasive and carry a burden of adverse effects. Now, just like recognition of stroke is complex, the treatment of stroke care is also fairly complex. So it would take a trained eye to recognize a stroke. In the same fashion, it takes a trained person to care for stroke. And because there's no other organ or part of the body that's as susceptible or vulnerable to lack of oxygen, lack of blood flow, in the pressure within the structure, there's no other organ that's as vulnerable as the brain. So when we take care of patients with other conditions, there's a lot of homogeneity and unifying factors that we care for and monitor for, which is somewhat different in the case of brain injury, whether it's ischemic or hemorrhagic or traumatic. So for that reason, people who are specially trained to take care of these patients, monitor for what's going on and expecting what could possibly happen, the complications that ensue these conditions. So if you have a set of people who are specially trained for these conditions to take care of these problems, patients ultimately do better. The outcomes are better because we are prepared to understand the disease and to take care of the complications when they happen. Having said that, the outcome in stroke many a time is not favorable. It's pretty bad, and that also goes, with the natural history of the disease. And it's important that we understand what the prognosis is of any condition, so that we offer the appropriate treatment and not, for lack of a better term, not just waste of resources, but it's important for the patient and their family members to make sure that the patient gets the best and the most optimal and appropriate care, not more or not less.
Okay. This is an interesting question. So it comes from Delia Carrasco. If you're having a stroke, how do you communicate if you are unable to talk so that you can get the help that you need?
That is an interesting question.
Very good question. Very good question.
Yeah.
So communication is not just talking. It could be just reaching out the phone and dialing a number, but we have to keep in mind that sometimes people are unable to, or it's impossible to even do that. Despite having good control of your arm and leg, sometimes there are strokes which make you completely aphasic, meaning not understand, the situation, be neglectful of the deficits. So that is something that we may never be able to completely address. Having said that, that does not prevent us from trying our best to recognize the symptoms as quickly as possible. That includes, or that involves, educating everybody about warning symptoms of stroke, because sometimes it may be a much younger person who would recognize the symptoms in someone elderly at home, or vice versa. So stroke education and stroke symptom education among everybody, including the public, the population, paramedics, first responders, nursing care, hospital personnel, doctors, that's key in treatment of this morbid disease, especially, yes. So I'm not sure if I addressed that question. Can you come again, please?
Okay.
Okay.
How do you communicate? Yeah,
How do you communicate?
yeah. So I think you may have touched on it, Alida, but let's talk a little bit more about why it's so important for patients who think they're having a stroke to call 911, and what that whole stroke system of care is that we have here in Kern County.
I had a lot of discussions with people about this. Well, I can get myself there quicker, they'll say, or I can drive myself. I just live around the corner, and who knows how long they're going to get. But not enough can be said about this, because we need to make sure that we are mobilizing that system of care. We do a lot of work in Kern County, as with many counties across the nation, to improve our system of care. We work very closely educating them. As Dr. Thomas said, the standards of care for stroke are changing so rapidly. So we keep ourselves abreast to all of these changes by continuously collaborating with them and making sure that that we know exactly how to respond, and ultimately saving time.
Okay. And what can paramedics do out in the field when they identify patients that may be suffering stroke?
What types of...
What role do they play in that stroke system of care?
So they're going to assess the patient, find out the history, find out the last known well. Hopefully there is somebody there that is a witness that will help collaborate that. Find out as much information as they can. They will start probably an IV, ideally, that will allow us to begin our workup. They are going to also check a finger stick. And by finger stick, I mean they're going to check the blood glucose levels, your sugar levels, because that's going to help us in our workup. So those are all initial things that can happen before you even get to the hospital.
Yes, the role of first responders or paramedics cannot be emphasized more in treatment of acute ischemic stroke care. The initial stabilization, they're experts in this, so we don't need to talk about that. But rapid recognition of symptoms to know that, okay, this is possibly a stroke, and then finding out, as Alida mentioned, when did this all start, because that goes a long way in determining what kind of treatment that we can offer the patient.
And as far as rapid recognition goes, too, Dr. Thomas had touched on this, but the idea of a large vessel occlusion and the opportunity that we have for treatment with those patients, there are some clinical symptoms that can help identify those patients. And we are working in Kern County on that recognition. It is now becoming something that these paramedics are doing in the field and recognizing, and that allows them to get them to a center that is able to perform these. Not everybody is performing this. So it's going to get them treatment quicker.
So one of the benefits of having a stroke system of care is a coordinated and a collaborative relationship with EMS. So as a stroke center at Memorial, as Alida mentioned, we work very closely with EMS and first responders. So one of the benefits of calling the ambulance, in addition to getting that initial assessment done, getting an IV in, getting whatever supportive measures might need to be taken for that patient, is they will communicate with us, with the hospital. So if they have a patient that has stroke symptoms, they will call us on the radio and inform us that they're bringing us a stroke patient. And that's a real benefit to the patient because it gives us the heads up, and we know that we need to begin mobilizing our stroke team in anticipation of the arrival of that patient. So might not seem like a big deal, but truly, minutes matter when we're looking at treating or assessing an ischemic stroke. Just like minutes matter in a heart attack, it's equally as important for those individuals that are suffering from stroke. So we don't see a real high percentage of patients that present to us in that treatment window. What are some of those reasons?
In the 4.5-hour window?
4.5-hour window.
I think symptom recognition, and we have hit this a number of times.
Yeah. So the lack of pain as a presenting symptom is probably one of the most important reasons why stroke is underdiagnosed and under-recognized and not treated the way it should otherwise be. So pain is a very compelling motivator to seek medical attention. So stroke, for most part, is a painless disorder. There are very few parts of the brain that can actually sense pain. For large part, brain is insensate to pain. Even though brain is what ultimately perceives pain in the rest of the body, the organ itself cannot sense pain except a few structures here and there. So it's essentially a painless disorder, and that may be one reason why people are not compelled or motivated to seek medical attention immediately or as quickly as they should otherwise. And by then, for example, if they're weak, they try to shake their arm and try, shake the weakness away or shake the numbness away. If they're confused or if they cannot get a word out, they may wait a little bit, saying that, okay, it's just going to pass by itself. Unfortunately, it probably won't. And even if it does, it still doesn't mean that, it's not going to come back again. So if you have a neurological symptom, and that means anything that's related to brain that you cannot clearly explain. So if you got a little tipsy and are slurring your speech, that may be okay. I'm not saying that you should. But if you cannot explain a symptom that you commonly associate with higher beings, higher individuals, I'm not saying that, I think humans are higher than animals, but just for the sake of this discussion, the higher functions that we attributed to humankind, if you have trouble with that, like vision, trouble understanding or producing language, trouble moving your arms or legs, sensation, those kind of things, you seek medical attention immediately without fail.
Okay. Especially if it occurs suddenly.
Especially, that's a very important point. So stroke is an instantaneous problem Unlike other problems that can affect the brain, like migraine or seizures, stroke happens instantaneously because it's a blocked blood vessel. So when the blockage occurs, the brain tissue cannot survive. Whatever territory this brain tissue, this artery was supplying or this blood vessel was supplying, cannot tolerate that lack of blood flow for more than a few minutes. So 1 minute you're fine, the next minute you're devastated. That's how usually stroke presents.
So we've spent a lot of time talking about ischemic stroke. Let's spend the last little bit talking about a hemorrhagic stroke, really what that is, what causes of it are, and potential treatment options for those hemorrhagic strokes.
Good. So hemorrhagic stroke is a second subtype, and about 20% of all strokes in general. And again, divided into several subtypes depending on where exactly the hemorrhage is. So the hemorrhage could be just under the bone of the skull. It could be within the layers that cover the brain. It could be within the brain itself. Depending on where exactly the hemorrhage is, you can have different causes for it. So it could be, spontaneous bleed inside the brain because of high blood pressure, where a tiny blood vessel ruptures. Or it could be an aneurysm, which runs over the surface of the brain within the layers of the coverings. And that's what we call a subarachnoid hemorrhage. So brain hemorrhage in general, and by definition, is more fatal. It can take people's lives because the skull is it's a closed structure. There's not much room for anything other than the brain inside there. So when you have a puddle of blood that's leaked out into the brain space, it competes with normal brain, and sometimes the blood wins. And for that reason, it could be fatal. And there are several reasons one could have brain hemorrhage from, including aneurysms, which are by far the deadliest. But it could be from just very high uncontrolled blood pressure and a tiny torn blood vessel.
So as far as treatment options,
Go ahead.
well, there's a lot that can be done, right? Both by neurosurgeons and endovascular, and we're so fortunate to have two endovascular specialists, neuro, and 3 soon, yes, at our facility that make us have 24/7. We're able to treat this
With our biplane technology that we have.
with the technology. Do you want to talk a little bit about that?
Sure. So coming back to the treatment, the key thing in treatment of hemorrhagic stroke is to prevent the hemorrhage from getting worse or rebleed. And certain etiologies, certain causes of stroke, has the propensity to bleed again or hemorrhage again. So that would be number one thing, to determine where the blood came from, why did the patient bleed, and treating the cause of that. And once that is taken care of, whether there's a primary reason or risk for re-rupture or not, then the next step is stabilizing the patient. Because, as I said, the most important thing is pressure inside the skull from the blood that's been leaked out. So that requires critical care, very close monitoring, sometimes several days of monitoring to make sure that it's not getting worse. And if it does get worse and if the pressure becomes uncontrollably high, there are medications that we can try to bring the pressure down, but most of them are usually temporary. The effects are not lasting enough. And the patient may need surgery, which is in the realm of neurosurgery. So they may need to open a piece of the skull and let the excess pressure off and let the brain cool down for some time, sometimes weeks or months. Definitive treatment of hemorrhagic stroke depends on what exactly caused the hemorrhage, whether it came from an aneurysm or an arteriovenous malformation, which is an abnormal tangle of blood vessels in the brain, or whether it was trauma and causing an epidural hemorrhage. So two things to keep in mind. One is treatment of the primary etiology, the cause of the hemorrhage. If it's an aneurysm, we go ahead and take care of the aneurysm, or AVM, we close off the connections. Or and the second thing is to treat the puddle of blood itself. And sometimes you may not need to do anything because blood over time, it will dissipate, it will get resorbed, and it will relieve the pressure effect with time. But during the time that the hemorrhage is getting worse, or the acute phase, when normal brain tissue can swell up around the hemorrhage, you need to make sure that the pressure is within acceptable limits. If not, you will need to drain the hematoma or the puddle of blood out, or, as I said before, a decompressive procedure where you take the piece of skull off and let the pressure up.
And so as far as an intracerebral hemorrhage, The main cause of that is blood pressure, right? That's what we see. The main etiology of that is a blood pressure. But when we're talking about subarachnoid hemorrhage, and we're talking about aneurysm, about how many percent of patients do you see that are aneurysmal related?
Of all hemorrhages, maybe like 15 to 20%.
Okay.
But when it is subarachnoid hemorrhage, it by definition is coming from an aneurysm until it's proven otherwise. Now, subarachnoid hemorrhage, deserves special mention because it's a very deadly disease. The mortality, the chance of a patient not making it after a subarachnoid hemorrhage is very high, as high as 50%. About half of those patients don't even make it to the hospital. The other half don't make it out of the hospital. Among the patients we treat, about half of those patients have serious neurological deficits. And this is not the statistics from Bakersfield or Kern County. This is all over the world. And when we see subarachnoid patients in the hospital that we treat, they usually have great outcomes. They walk out of the hospital, or they return to their normal, meaningful and productive life within a few weeks. But you should also keep in mind that there are a lot of patients who have subarachnoid hemorrhage, they don't even reach the hospital. So that number is substantial. Now, for that reason, subarachnoid hemorrhage, when it occurs, it is presumed to be coming from an aneurysm unless it is proven otherwise. So that is a special disease category that deserves special mention and a very important place in stroke recognition and symptom recognition.
And so there are two treatment options currently for aneurysmal subarachnoid hemorrhage.
That's right.
And since you perform one of those, would you like to elaborate on that?
So treatment options for the acute treatment or the immediate treatment for aneurysmal subarachnoid hemorrhage is taking care of the aneurysm itself. So aneurysm is like a blister on a blood vessel. So there's a weak spot in the blood vessel, and because blood is pounding on the wall with every heartbeat or because of the high pressure, that weak spot may balloon out, and at some point it may rupture. So that is what causes subarachnoid hemorrhage. Unfortunately, the aneurysm does not cause any symptoms that people can recognize until it ruptures. So, one moment the patient is completely fine, and the next moment you have a thunderclap headache, which is usually the hallmark feature of a subarachnoid hemorrhage. And many a time the patient just passes out and they go into a coma, or they may be plegic or weak on one side. They can have severe morbidity from that. And so the immediate concern is to make sure that the aneurysm, which has ruptured already once, because continued rupture or continued leakage of blood from an aneurysm is not compatible with life. If that happens, those are the patients who never make it to the hospital. Right? The patients who make it to the hospital are those where the aneurysm ruptures, leaks out a little bit of blood or a fair amount of blood, and then the bleeding stops, until it bleeds again. So that is the golden window for us to go and intervene and take care of the aneurysm. And those aneurysms, those ruptured aneurysms, have to be emergently dealt with. So preferably within the first few hours of the rupture, the aneurysm should be secured, meaning that blister should be taken care of. And there are two ways by which we deal with aneurysms. One is open surgery, and that means that's a neurosurgical procedure, open neurosurgical procedure. You open the skull, visualize the aneurysm, see the blister, and put a clip, just like a clothesline clip, but just more expensive, and across the neck of the aneurysm. So that should take care of the aneurysm from bleeding again. The second way we treat aneurysm is endovascular. Again, just like ischemic stroke, we use the same route going through the groin, getting catheters, threading them all the way to the base of the neck, taking pictures of the aneurysm, and then using another set of catheter to go inside the aneurysm and filling the aneurysm up with platinum coils. These coils are like slinkies. They come in various sizes and shapes.
Only
and we
more
fill
expensive.
Yeah. Well, the idea is to fill up the aneurysm with these coils so that blood does not get into the aneurysm anymore, and thereby securing it. Both these procedures are available in Bakersfield, and endovascular treatment of aneurysms has a substantial advantage that it's much less invasive, and someone who has had a hemorrhage, it is probably not the best to go for open surgery, because the patients are already in very morbid condition. They may not be able to tolerate the stress of an open surgical procedure.
Thank you.
There, I like how you touched on the thunderclap headache, because you did mention that stroke does not have pain. And I would like to just elaborate a little bit more on that, because subarachnoid hemorrhage can have pain.
Yes, you know, in fact, that's the most common symptom of subarachnoid hemorrhage, a thunderclap headache, a headache like one has never known before. And it's very, very unusual for a patient to mistake that for, you know, one of their normal headaches. And the reason, as I mentioned before, you know, the brain is largely insensate to pain, except certain structures. And one of those structures is the meninges, the covering of the brain, you know, in which the brain is housed. And when you have subarachnoid hemorrhage, you are leaking blood into the space between the surface and this covering. So increasing the pressure there and stretching the membranes. So that sudden increase in pressure, sudden stretching of the membrane, the subarachnoid membrane, the dura mater, is what causes the severe headache. And again, it's instantaneous, because one moment the pressure was normal, and the next moment it's like shooting up through the roof. So they describe this as a thunderclap headache, and the worst headache of their life. If someone has that, it has to be again treated as aneurysmal until it's proven otherwise.
We get very concerned when patients present to the emergency department with
The
worst headache
of
they've
their
ever had in
life.
their life. People take notice of that kind of complaint. So I think we are, we're closing in on our time. Any final comments y'all want to make about Stroke Awareness Month?
You know, I want to go back to the comment that a family member made. I don't want to bring up the name again. I'm not at liberty to do that. But I want to mention to him as well as the public that even though he mentioned my name in particular, it was not just me. In fact, in that particular case, I only had a somewhat minor role to play. You know, it was a team of people, right from the paramedics who brought the patient to the appropriate center. It was the nurse who took care of him, the ER physician who immediately recognized that this could be something potentially dangerous and got the appropriate tests, recognizing the symptom, having the facility and the technology to diagnose the problem immediately, and then the neurosurgeon in this situation, I will take the liberty of mentioning Dr. Abu Mary, was available and had the required skills. So it was never one person. It is never one, machine. It is a team of people, and more important than that, a protocol. This is a program-driven specialty. So you have to have all these elements in place for this to be working effectively, safely, and efficiently. So thank you for mentioning this. But I would like to clarify that it was teamwork.
Thank you. It is. Alida, any comments?
No, I'm grateful to have this opportunity to share this with people, and hopefully we've taught you something.
Okay, so as I mentioned, May is Stroke Awareness Month, and Dignity Health is sponsoring a couple of events where you can learn more about stroke. We've got an event on May 14th, Spot a Stroke, Save a Life seminar. That is going to be presented by Dr. Alexin, a local neurologist in town. That'll be held at Mercy Southwest Hospital. Also, Spot a Stroke, Save a Life, same type of presentation, will be held on May 29th, and that will be presented by yours truly here if you want to see him again. And then also we have a Stroke 101 seminar, Prevention, Symptoms, and Treatment. And that seminar will be presented at Kern City. So for more information on any of these three events for Stroke Awareness Month can be found on our Facebook page for more information. So thanks for joining us today, and we appreciate your questions. Hope you learned something about stroke recognition and awareness. Have a great day.